welcome to this great session. I don't mind to raise the expectation because I've seen it all. It is indeed a great session. My name is Emanuele Barbado, interventional cardiologist from Rome in Italy. And this is the reasons why we have gathered this group of colleagues here to discuss with you the real-world clinical case on how to optimize treatment pathway for coronary artery calcification, supported by new clinical data. We'll discuss, and you will see lots of new clinical data here. We're discussing together the framework for selecting the most appropriate device for vessel preparation based on calcium burden. Anatomical consideration and patient gender will all be discussed during this session. And finally, guess what? You are in a shockwave session to explore the role of IVL as a first-line treatment strategy for managing coronary artery calcification and its impact on procedural outcomes. This is the team. On this side, Angela McInerney from Galway in Ireland, Marco Pavani on rather left side here from Turin, Italy, Simon Wilson on the right, London, UK, Margaret McIntyre, New York, US, Tu Olsen, Copenhagen, Denmark. Of course, you don't see Nieves and Javier because they will be performing the live case, the recorded live case for us. Be part of this team. We actually made sure to wait that your lunch was over. Why? Because we wanted you to speak and interact with us. You can do this either through the chat box or taking one of the standing microphones in the room. With this, let's go to
My name is
Madrid.
And we're going to perform this case here together with Javier Scanet. We're going to introduce this case of a very severely calcified lesion. And our fellow Julia Nardi is going to introduce the case for you. Please, Julia.
Good morning, everyone. This is a 73-year-old female with arterial hypertension and type 2 diabetes as cardiovascular risk factors. And her past medical history started in February 2014 when she underwent a PCI of the middle LAD and circumflex and distal LCA for a severe calcified three-vessel stenosis. In a few months later, a new coronary angiography was performed that showed the optimal result of the previous PCI and absence of de novo lesions. The patient remained asymptomatic until March, when she was admitted to our hospital for stable angina and a dyspnea with an EA class of 3. EKG was normal without any changes of the STT segment, and the echocardiogram showed a preserved ejection fraction, an inferior wall hypokinesia, mild mitral regurgitation, and absence of pulmonary hypertension. The laboratory tests were quite normal with a normal renal function, and this is the coronary angiography showing a good result of the previous implanting stent in the mid-LAD with a moderate in-stent restenosis of the left circumflex that seemed to be intrastent. But the problem was the right coronary artery that showed a very long and severe calcified lesion of the RCA in the proximal and in the mid-segment, as you can see also from this view, and with a good result of the stent in the distal RCA. So to resume, this is a 73-year-old female with a stable angina, preserved ejection fraction, a good result of a previous PCI in the LAD and the distal RCA with a moderate stent restenosis of the middle circumflex and a severe long calcified lesion of the proximal and mid RCA.
Thank you very much, Julia. So this is the procedural strategy that we've been discussing, Nieves. Basically, we think that this is a case that obviously we need to perform with imaging guidance. We are going to be using OCT in this particular case because we believe that will give us information very specific about the characteristics of calcification in the right coronary artery. Of course, we anticipate the importance of performing a lesion preparation, and for that what we have considered is the use of IVL, which will be a very important tool in this particular case. We are going to see the specific value of this technique. And then the stent length will be, and the diameter will be also assessed based on or chosen based on intracoronary imaging. We will, of course, use that to optimize the case as well. On top of that, we will be also performing pressure guide wire in the, so to speak, moderate restenosis that we see in the circumflex coronary artery. Now, there is a bonus in the planning of the case that comes from the availability of a CT angiogram. And what we've done is we performed this analysis with a contemporary platform that allows us to see very clearly the amount of calcification that you have in this case is huge, as you can see. You can see in this particular case that there are different patterns of calcification at the lesion that we are going to treat. You have both concentric and eccentric patterns of calcification within the same lesion, as typically happens, of course.
A very typical case from EmpowerCAT, this study that has been performed only in women with calcified lesions, a very innovative study really because all the patients were females. And this is the typical type of patient we had in the study. So this type of tortuous vessels with calcium, typical from ladies. So I'm going to show you what we have done until now. Until now, we have just engaged the vessel. I have to say it was quite challenging. We had to use, in the end, an AR1 with an extension catheter because otherwise it was very difficult to engage. We crossed with a wire, and we are now in this situation. You can see here that now we're going to go with the OCT, try to see if we can get good images baseline from this. We're going to try to do OCT first, see if we can cross this lesion with the OCT. Yeah, it's going well.
So Nieves, this is what we see here in terms of automatic selection of the segments. Here. Look into the lumen profile is not bad. Perhaps, would you agree that perhaps we can go here in the proximal part?
Yeah,
because we have a larger vision.
Well, we have a larger area, yes.
I'm going to select that as the proximal. And that tells us that basically we will need something like a 28 millimeter stent for that particular length.
Let's have a look at the first of the calcification and the patterns of calcium inside the lesion, and then we select the. We go back to the landings and check the vessel size. Okay, so I'm
advancing now from proximal to distal. We can see the arc of calcification highlighted in orange there, which obviously here is more than 180 degrees already.
If we go a little bit into the details of the calcification, we can see here, for example, there are areas where we have, of course, more than 180, 200, and also the thickness is very high. So you can see, for example, in this area is 0.69. It's not even the area with more calcium. We can go actually to the area of the minimal lumen.
Okay. I'm gradually advancing more, approaching now the segment where we have the tightest, and it's very heterogeneous, as we also saw in the CT.
Yeah, so again, a lot of thick calcium, mostly concentric in this area, but more than 180 very thick calcium.
And this is the tightest area.
This is this is the tightest area. So it's and you can see here we can see calcium on both sides. No? So here is if we look at the numbers, for example, or how the system identifies the calcium, and we go to the measurements.
Yeah, I'm trying to do that.
For example, here it's almost 300, and the thickness of the calcium is 0.85. So again, everything pointed in the direction of very thick calcium, eccentric in some areas and almost concentric in some others, as so concordant with what we saw already in the CT angiogram. What is interesting is that we don't see any areas of nodular calcification. So this is calcium that is inside, let's say the wall is not protruding, so we don't see nodular calcium. It's a lot of concentric and eccentric calcium, but we don't see any signs of nodular calcification, which is, a completely different pattern. So I think that looking at this type of calcification, it's a long lesion, calcified, some areas almost concentric. I think it's is actually a type of calcium that can work very well with IVL.
And this is we are approaching now the landing zone, which of course has disease, but it is certainly much better place.
This area is very nice. You can see that actually the system is able to identify here the EL because it's very small, only intimal thickening, so you can see almost the EL of the vessel in the whole circumference. And we can see that it's a huge vessel at this point. It's 4.5 almost. So so really big vessel at this point. So this will be the distal landing. If we go to the proximal landing, Javier, and
proximal landing is also very good.
The proximal landing, which is also very big. In this case, the system is not able to identify the EL because we have a lot of calcium in all the, almost 270 degrees. It only identifies the EL in some in the upper segment. But for sure, I mean, you can see the lumen is 3.7, so I think it's a large vessel. Thinking of the size of the balloon that we're going to use, the IVL balloon, I think that probably we can use a 3.5 to go on the safe side with this proximal part where we have disease, or maybe 4 could also be possible, but I think a 3.5 would be fine, seeing this vessel size.
Great. So you've seen this patient. It's not an exceptional patient. It's actually a common situation that happens almost every day in our cath lab. We do see this calcified segment. We have seen also the morphology of calcification. And to Simon, we asked to really dissect the images we have seen and to make them actionable. What can we do with these images? What to do with that, Simon?
Thanks, Prof. I mean, the job's already done. They've gone through it so eloquently, haven't they? But let's break it down in a bit more detail. This is a very typical case that we encounter in everyday practice, isn't it? Calcific coronary disease. It's increasingly common, really, because we're taking on more and more of these types of cases. So we've got loads of information available to us. We've got the CT coronary angiogram, we've got the angiogram, and we've got the OCT images. But how do we put it all together? That's the big question. Really, we're at the point in the case of what do we do next? Or in other words, what device do I choose next and why? And there's lots of algorithms available, and many of us in this room were responsible for creating them. And I think on reflection, if we look back, we perhaps didn't do a good job because we've made them overly complex, would be one of my big criticisms about them. And if they're overly complex, they're difficult to remember. And if they're difficult to remember, you don't really implement them. And if you don't implement them, what's the relevance? So that would be my first criticism of available algorithms. The second thing is that, our understanding of shockwave has evolved a lot recently. Where it's effective and its safety profile, and that is not reflected in current algorithms. And the final thing, and I think this is really relevant, while the guys are trying to bring up my slides, is that algorithms just now are very myopic. They just focus to ask you to think about the calcium morphology, nothing else. They don't step back and think about the bigger picture. They don't ask us to think about factors that can really influence device-related procedural and patient safety. That has to be the forefront of decision-making, surely. So with that in mind, we developed the CALC calcium roadmap. And it really is, I'm talking out loud now, it really was, it's 3 simple steps to help us, 1, determine when further lesion modification is required. 2, if further lesion modification is required, what factors do I need to consider? What are the things I need to think about that are going to inform device performance and safety? And the third thing, having considered those factors, when is IVL suitable? Is IVL suitable for this lesion in this patient? Or perhaps should I consider another device? So, without the slides, CALC, I'll just go through the letters. CALC, CALC. Obviously, we used it because it's sort of an acronym for calcium. C stands for calcium type. What has that got to do with device selection? Well, it really comes down to, there's 3 types of calcium. There's concentric, eccentric, and nodular. And what has that got to do with device performance and safety? Honestly, it comes down to compliance, patterns of compliance. If you think about concentric calcium, that causes uniform non-compliance. But eccentric and nodular calcium, that causes non-uniform compliance. You've got low compliance where the calcium is, and you've got higher compliance on the opposite side of the vessel, and that is a huge problem for a balloon-based device. Because logically, if you think about it, if you apply more and more pressure, and that's how those devices work, the balloon's just going to inflate away from the calcium. And the performance of balloon-based devices really relies on overstretching of the non-calcific quadrants, and that has limits. And if you apply more and more pressure...
Can you try to advance, Simon, because they're telling us that normally your slide should be in there.
Ah, here we go.
Okay, you made it a try. Huh? I mean, you wanted to do it without, but you have it.
I've been through it so many times. Okay, so this is the compliance. This is the problem. If you inflate a balloon where there's non-uniform compliance, it's going to expand away from where the resistance is. And as I say, it's got limits. And if you put more and more pressure in there, there's going to be a problem. Shockwave is different, though. You know, the clue's in the title. The performance or how it works is based on the power of shockwaves, which, when they're produced within the vascular space, are highly selective for calcium. And of course, shockwave, we know, doesn't rely on high pressure. So those two things are a huge advantage. And the performance of shockwave lithotripsy is not dependent on or not affected by the pattern of compliance. So that's a big advantage in eccentric and nodular calcium. What about lumen size? Well, this is a typical example here. If you've got a large vessel, you can actually have a larger lumen within an obstructive segment. We see that a lot. What's the relevance of that? Well, as the lumen increases in size, the likelihood of having an unfavorable wire bias goes up. That's obvious. It's intuitive. And if you have an unfavorable wire bias that you can't resolve, an atherectomy device is going to be of no value. IVL and balloon-based devices, they're not influenced by or affected by wire bias. Finally, let's talk about depth. Well, most of the calcium encounter is superficial, but it's not uncommon to encounter deep calcium. An atherectomy device is going to be hopeless in deeper calcium because it doesn't touch it. That's obvious. The performance of a balloon-based device, well, it's going to be affected by pressure diffusion. Lithotripsy, less of a problem. The shock waves can travel right through the vessel wall and they'll disrupt any calcium they encounter. So IVL is perhaps best suited of all the available devices to dealing with deeper calcium. So we got this CT coronary angiogram. Forewarned is forearmed. You heard Javier talking about it already. It tells us that we're dealing with concentric calcium here, and further down, eccentric calcium. That's important information. Let's move on. Okay, so the OCT, does that confirm our suspicion that there's mixed calcium? Yeah, it does. If we look at the proximal vessel here we see there's 180 degrees of calcium here. The smart screen's not working, I'll just tell you that. So that's eccentric calcium. I'd be comfortable with calling that eccentric calcium. As we come further down, more eccentric calcium. The AI's telling us there's eccentric calcium. But when we come into the obstructive part of the lesion, or the most obstructive part of the lesion, there's concentric calcium. You see calcium on both sides of the wire there. So concentric calcium there, and concentric calcium there. Okay, let's move on. The area. I think within the most obstructive part of the lesion, I'd say that the lumen is on the smaller side, and we're lucky enough to perform the OCT here. So we've got a favourable wire bias here if we wanted to use atherectomy. I think that's okay. I'd be happy to use atherectomy here. But let's move further on. Let's look higher up here. You see the lumen area is only 3.8 millimeters squared. The reference is 10. So we've got to fix this. We can't just implant a stent in there. There'd be a residual stenosis of 60–70%. So we've got to resolve this part. But the lumen size is bigger and there's an unfavourable wire bias. So I wouldn't feel so happy about using atherectomy here. Move on to length. They've done the job for us. This is the proximal landing zone. I'm happy with that. There's a nice area to land the stent. This is the distal landing zone. Very healthy vessel here. Okay? And then it tells us in the middle here, done the job for us, 28 millimeter stent. So it's a sort of 4.0 vessel here, and a 28 millimeter stent. That's what we're planning. And I think that's important, actually. You know, at that point in time, in terms of case efficiency, you want to ask and make sure we've got a 4.0 28 millimeter stent in the room. Okay, what about depth of calcium? So in the most obstructive segment here, I think this calcium is superficial. But look at this as we come further down. Okay, it's starting to get a bit deeper. We've got some fibroatheroma tissue in front of the calcium, so it's going to be a problem for atherectomy. And look, if we come right down to the bottom of the lesion here, it's very deep calcium there. So an atherectomy device is not going to do anything. Balloon's going to struggle because of pressure diffusion. IVL makes sense here. Finally, the last letter on the algorithm is complexity, and I think that's very important. We don't need to go into too much detail today. But in this case here, we've got an elective patient, which is important. Elective patients compared to ACS patients are completely different, in my opinion. We've got a mid-RCA. This is not left main. Okay? It's single vessel disease. There's a little bit of tortuosity, but nothing that would, scare us. And there's no thrombus. So I don't think there's complexity issues or safety issues in terms of device selection. Okay. So that's me done with this bit.
Thank you very much, Simon. It is very much pointing towards the direction of intravascular lithotripsy here for a number of reasons that were just illustrated now by Simon. At this conference, there were the data presented from Bali trial that is specifically dealing with plaque preparation before stent implantation. And Tua has been the PI of this trial. Can you tell us a bit about this trial? Because we will pitch some of the results while we go in this session.
Yeah, certainly, Emanuele. Thank you very much. Yes, we presented the results of the Bali trial yesterday, which are very relevant for a case like this. So this was a multinational randomized control trial in 9 European centers with randomizing patients with severe calcification on angiography for an IVL early strategy versus a conventional strategy not encompassing IVL. Specialized balloons were allowed in both arms. Rotational atherectomy were allowed in both arms, and the procedure had to be OCT guided. So the endpoint for the trial was a composite endpoint of procedural failure, which was missed stent delivery or a residual area stenosis above 20% by OCT, or target vessel failure at 1 year. Sure.
Hold on that,
sure.
Because we'll get back on that later on during the session.
All right, I need to tell the results.
Yeah, but they need to stay here till the end of the session. They will get the results. Why don't we go with the first poll?
Mm-hmm. Yeah, so the chat is actually lighting up here, Emanuele, with lots of questions about the technical use of IVL. So I think the first poll is actually very timely. And if you want to open your apps, you'll be able to reply to this poll and also scan this QR code. So when you're selecting an IVL balloon, and we'll see what Javier and Nieves did, how do you size your IVL balloon? Do you use vessel measurements using EEL to EEL based on your intracoronary imaging? Do you use lumen measurements? Or I'm not quite sure how to size the IVL balloon. It'd be interesting to see what the panel have to say as well. So you can vote now, and we'll look at the results at the end of this discussion.
And perhaps we can start just from this point and get back to you now.
Sure.
To advance a little bit further, but try to address this point already.
Yeah, so for IVL, there are several things to consider. For the shockwave balloon, there's not really a possible benefit of going lower. And it's very important for the IVL technique to work that you have full apposition of the balloon to the vessel. So sizing to the vessel, to the true vessel, is the standard of care here. That would be my comment.
Yes, just one point. What about if you have a tapered vessel? So if you have a proximal LAD starting for 4 millimeter and you have a distal LAD that is around 3, how do you select your balloon? According to the distal part, you go up to 4 atmospheres, and at the proximal part that is 3.5, you go up to 8, 10 atmosphere. You don't go over 4 atmospheres.
So generally, the technique is not more effective if you go up in pressure. The intention of dilating the balloon is more to get a position of the balloon to the vessel wall, actually. So I would size to the distal part and see what happens. And if needed, you could get out a larger balloon for the proximal part.
Shall we have a look at the result of the poll? There we go. Any comment from Margaret?
Yeah, and I completely agree with what was said already. So I usually size it 1-to-1 with the EEL measurement, which is kind of in contrast if you're using a cut and balloon where you will downsize your balloon to your vessel size, especially if you want to go to high pressure. There are some circumstances, as you've described, where you have a tapering vessel where you have to kind of sometimes compromise, or you're going to have to use two devices. And actually, often that's okay, because if you've got a lot of plaque, and especially if the calcium is not too deep in the vessel, as you modify the vessel from distal to proximal, you will get some efficacy of the IVL even in the bigger vessel, as long as the balloon is opposing the plaque. That's the key thing. So you have to look at what your luminal dimension is at the bigger segment of the vessel if you're going to use a smaller balloon, and make sure that when the balloon's inflated, it's going to be up against the plaque and deliver the pulses.
All right. If we can go back to the case or to the slide, please, so we can just advance and see what did they do in Madrid. Let's see if it works.
So we have, I think, all the information we needed. So no nodular calcium. We have concentric and eccentric. We have a long lesion. We have good landings. I think that seeing that the OCT crossed very easily, let's see if we can, using the guide extension, let's see if we can directly go with shockwave, or would you recommend to predilate? What would be your strategy here, Javier?
I think I will try and do my best to go directly with IVL. Obviously, there will be no problem whatsoever in predilating with a 2.5 millimeter balloon or something. But we can try first to see how it goes. I mean, the generation we have now, IVL, has good navigability. So let's go with a 3.5 IVL balloon.
So, yeah, I'm advancing the balloon, and actually
It crossed.
It crossed really well. You can see that we have the extension catheter up there. And I think with the help of this...
dynamic coronary mapping is showing...
Yeah, yes. With the help of the extension catheter, it crossed quite easily. And I think we are now almost in position. You can see here the coronary road map, where we can see that we are in the region we want to treat. We also have the co-registration from before, so I think we can start there, applying the pulses.
Okay.
Okay. So let's...
So we go to four atmospheres, as typically we do, and now we start the erosion.
Now, in detail, we will talk a little bit in detail about the positioning of the balloon to provide the pulses. As you know, the position of the emitters and the position of the radiopaque markers is not the same. So in this situation, for example, where we have this long lesion, of course we need to apply pulses in all the lesion, but of course we want to concentrate most of the pulses in the area where we have more calcium. That in this case we saw it was very close to the MLA, where we have more concentric calcification. So we will check now with with the stent boost the location of the emitters. We can do actually here on the stent boost, so we can show you the position of the emitters. Let's say that.
Good. So we can see the location of the calcium is good. The emitter looks in a good position.
Yeah.
there.
So actually, one of the emitters is located just in front of the calcium. I think that then later on we need to go more proximal to the other area of calcification. But we can apply a little bit more pulses here.
So something that perhaps is relevant. You notice that in the first inflation we noticed some bubbles, and what we have done now is to purge the system, make sure that there is no air. Or any gas that is generated during cavitation, because otherwise the effectiveness of IVL gets reduced. So I have purged the balloon a couple of times, and now you can see that there are no bubbles there. Sometimes the bubbles develop during the course of IVL, so you have to be careful. Another aspect that is very important, Nieves, is that we can see that the center line of the balloon is centered, so there is no displacement. The balloon is evenly expanding in all directions. That's a good signal, isn't it?
Yeah. Let's go a bit more proximal, because we were a bit distal to the area with more calcium. So let's move here now to tightest part of the lesion, and we're going to continue applying.
Okay, so we go to 4 atmospheres again. Good. Yeah, okay.
About the number of pulses, I think our general strategy is try to apply all the pulses and take advantage, of course, as much as we can of the preparation that we can achieve with this.
Perhaps we can show a bit the EKG to show that there is no ischemia, that the patient is tolerating this very well. We can show it for a while. Okay, and we are also going to show now the effect of the pulses on the EKG. Which, typically you can see these spikes, which rarely have a major effect. Okay.
And again, looking at the expansion of the balloon, the position of the wire, we can actually maybe in the next one check also into views, make sure that the balloon is expanding properly into positions. Yeah. Also again, to check the position of the emitters and the calcium. You can see again that actually we are here very well in front of the calcium, maybe a little bit more distal. Let's go. Yeah. Let's continue with the pulse.
4 atmospheres. Okay, go.
So we have applied already half of the pulses, the 16.
And we now move to more proximal one?
Yes.
Something like this?
Yeah, something like this.
Okay. So still more than 180 degrees of calcium here.
Yeah, it's...
Okay. Oh, look at that. What is that? Is that error, or I think it's...
Doesn't look like it.
Okay. Okay, I'm going to remove this.
Yeah.
Let me just make sure that there is no error whatsoever there, but it's... I mean, one of the learning points of this RAP cut is that actually the maximum degree of calcification rarely coincides with the tightest point of the stenosis. So 4 atmospheres, yes? Interesting.
Mm-hmm. Yeah.
So this is very interesting.
Area of, under expansion, no? I mean, under the expansion of the balloon here. So clearly we need to work a little bit more in this area.
Okay. I believe, Nieves, that this is the area that we are having difficulty there.
Yeah, it's in the entrance of this of the tightest part. But you can see already that from the initial pulses, after 20 pulses, is already looking much better. So we're going to apply a little bit more pulses there.
Go. 4.
But it's interesting because it looked all very pleasant. You can see now it's open, no?
It's getting better and better, yeah.
Yes. It looked like everything was going, but then you get these areas that are more resistant. So that's why it's important when you treat this type of long lesions to go slowly, moving your balloon, make it forward easily. Before there was some resistance to go. So I move it a little bit more distally, and we're going to apply pulses here and make sure that the balloon opens well in this area. You can see now there is
much better.
A difference, yeah. Now it opens much better. It's actually this area, no, where you see the wire a little bit closer to the size of the...
But it still needs some more work, eh?
Yeah, I think so. So let's apply it here because it's where
4.
We had this area. It's looking much, much better now.
It is getting better and better.
Yes. Okay.
Okay.
So we applied the 120 pulses along the lesion. And I think it's now time to check the result with imaging again. Let's see now the effect of the therapy.
So now we have to go back
to move the
because now
interest, It's interesting just to see, even without looking at OCT, looking at the angiography, imagine the great gain in lumen area that we have achieved only with only with shockwave. Look at it. I mean, it looks increasing MLA is amazing.
So we start from
MLA
proximal.
Now is 4.0. No?
Proximal to distal, Nieves. So I think that we are approaching the area where we have more resistance. That was probably this area.
Yeah.
There are some ruptures here. You can see some.
Yeah. So yeah, let's move to this view so we can appreciate better the lumen and the fractures. So this was the proximal landing, no?
Proximal landing. Yeah.
Now we enter the area where we apply therapy. You can see
maximal calcification around here. That's a plaque rupture.
A significant increase in lumen area and some irregularities, some fractures in the calcium that you can see.
9 o'clock
there. Yeah. And 3 also.
3 o'clock.
Fracture.
Yeah.
This was actually the area where we have more resistance. So this was the area where big fracture there. Again at 9.
Big fractures.
Again, it looks this is thick calcium. It's pretty superficial. So again, very appropriate for this therapy. Concentric and eccentric, superficial.
That dissection, you can see it angiographically speaking.
Yep.
We have a look to it. We'll see it in a second. But so
it's the dissection we see also in angiography.
Yeah. You can see some fractures as well there.
It's actually like it's a dissection, but it's part of the calcium. That is now fractured.
Again, a part of section there. It's entirely normal because it's detachment of the plaque, right?
Yeah, exactly. We go back again to the measurements just to confirm what we had measured initially.
So for the proximal part, I think 3.74.
This is a lumen measurement, so probably the vessel is 4. No, it's only that you cannot see the vessel because there's still a lot of plaque there. But for sure, I think with a lumen of 3.7, probably a 4.0 balloon
4
should be
will
okay.
be fine, yeah.
And if we go distally to the other landing zone, here you can see.
Here we have a nice measurement of the EL, Nieves.
Yeah, which is 4.5. And the lumen is 3.4. So I think, again, looking at the proximal and distal, knowing that the proximal reference, we have some disease, I think 4 is a safe option. I think 430, the length we have here between the two references is 30. I think this should be okay.
Now the question is, Nieves going to perform the further predilation with a high-pressure balloon, or we are happy with the expansion of the 3.5 IVL balloon?
I think I would be happy with the expansion of the 3.5. We also have a bit dissection here, so I'd rather not continue with dilations, and I think the stent is gonna expand very well because the plaque is very well prepared. I don't think adding a 3.5 and see will add anything else here. It's something that if you're not going to use imaging, you want to make sure that you expand properly. But in this case, we have seen in imaging, I think I would rather go to
a structural modification of the plaque with fractures, etc. So we anticipate that the compliance of the vessel has been improved a lot, and then we can do it. Okay.
Exactly.
So that was the opinion of Nieves and Javier concerning this particular stage of the procedure. What is your opinion on the need to further modify this plaque? Can we have the second poll? Is this the second one? There you go. Yeah, so if you can vote on that. In the meantime, we've got a lot of questions in the chat box.
Yeah, so the chat is really very active and lots of technical questions being asked about the use of IVL. So the poll is actually one of those technical questions, which is whether or not post-dilation is always needed. It's not needed always if the IVL balloon expands, and no post-dilation is only needed if fractures are not present on the intracoronary imaging. So this, in fact, actually was one of the questions in the chat. So we may as well take the opinion of the panel. So Margaret, do you always post-dilate after your IVL balloon, and how do you assess that you have modified the calcium enough? Let's say before you do your imaging run, is there any sort of checks that you do so that you don't have to do multiple imaging runs?
Yeah, so not always. You should never do anything always.
Yeah, sure.
Or anything never. So situations like this where you see on the imaging that you've created quite a lot of vessel injury, or if you see a lot of hematoma, and if I'm convinced that the calcium modification on the imaging looks adequate, I would tend to be more conservative. If I was to use a non-compliant balloon, I would also be conservative with how I used it. So I would size it 1-to-1 and just go to like 10 or 12 atmospheres and check the expansion in multiple views. You don't have to always take your non-compliance up to 18 or 20, especially if you've seen a lot of vessel injury on your imaging run, right? So if you're going to do it in a situation like this, be careful because, there's no need to be aggressive. So one situation in which I will do it, though, is if there's areas where I'm not completely convinced that I think that I've adequately modified the calcium. And sometimes even with imaging, you can't be completely convinced. And the only way to do that is to take a 1-to-1 non-compliant and look at it in multiple views. So I tend to use as much information as possible because the worst thing you can do is end up with an underexpanded stent. But if you're going to use it when you've got vessel injury, don't feel you have to necessarily go to high pressure.
Yeah. Right. Sorry. I feel the same. I mean, but the acid test is the balloon. It's the only thing that reliably tells you compliance is okay and you're good to stent.
Sure. And then another question, maybe, Thule, is do you always deliver all of the pulses? So you saw Javier Neves, they delivered all of the pulses in this lesion, which was about 30 millimetres in length. So is that something that you always do? Do you have a way of determining whether you've given enough? Or do you like to always use all of them because you've already paid for the balloon?
I like to use a lot of the pulses. We also mandated that for the Bali trial to actually go for using most, if not all, pulses. I think personally I like to keep a couple of series on the balloon. So if I see something on imaging, I can go down and add treatment with the same balloon.
And Marco, just one final technical question that's also coming into the chat is when you do have long lesions, and you kind of alluded to this earlier about sizing your balloon, but the audience is wondering, is shockwave something that you deliver all the pulses to one area, or should you move it along your lesion or your vessel if you have a long length of calcium?
Yes, I think that I will go according to the intravascular imaging if it's possible, because if you have some very thick calcium, probably I will try to keep my guns, the true emitters, in front of the deepest calcium, the deepest calcification, in order to deliver as much as possible the IVL energy there. And I think that this is why intravascular imaging is so important.
I think that's really great answers. Will we look at the poll?
Yeah, let's have a look at the poll and then get ready as we get back to you to discuss a little bit further the Bali trial results. Yes, post-dilation is always needed, 50% of the cases, which is not exactly aligned to what we were suggesting. Tua, your trial was really about early IVL treatment in this case. How many times was really needed to pre-DIL before IVL? How many times was it needed to post-DIL after IVL before stent implantation? Give us some more insight.
Yeah, we have some data on that. So it was often needed to do something before passing the balloon because the IVL balloon is relatively bulky and calcified lesions tend to be severely tight. So actually, in 81% of our cases, we needed to do something before passing the shockwave catheter. In 30% of cases in the IVL arm, we did rotational atherectomy before. That is actually a lithotripsy strategy there. And in the rest of the cases, we pre-dilated with a small, undersized balloon to allow passage of the balloon catheter, the IVL catheter.
I see. Would you disclose now the results of the trial?
So the result is it was a positive trial. So IVL was superior to to conventional therapy with a risk reduction of 31% at a P of 0.02. Both components trended in the same direction.
So fantastically positive. From trial to trial, Margaret, how about the Empower CAD trial results? It would be great at this point if you can disclose some of the relevant data. The clicker is for you. There you go.
Okay, thanks very much. So I'm going to show you the data from Empower CAD, women with calcified coronary arteries treated with IVL that we presented as a late-breaking trial yesterday at the same session. So we know that women are underrepresented in PCI trials, so usually about 20% of the trial population. And this was also true for the Disrupt trials, the IVL trials that we're all familiar with. We know women are diagnosed at an older age, have more comorbidity and more coronary artery calcium. We know also that they have a higher associated mortality when they have calcified lesions, and they also have higher complication rates when you treat calcified lesions, especially when you perform atherectomy. So it was in this context that we designed and performed the Empower CAD study, a prospective multi-centre single-arm observational study in female patients with calcified coronary arteries that were being treated with IVL. So study design, so we selected 399 patients. This was based on the fact that we wanted to end up with data and the same number of women as were men in Disrupt. So we're kind of equaling the data sets between men and women. So 399 women enrolled at 45 sites, Europe, the US and the UK. The inclusion criteria was deliberately real world. We wanted this to be a real world trial. So as soon as an operator decided they wanted to use IVL in a case, whether that was based on severe angiographic calcium or imaging, and the IVL was opened, the patient went into the study. So the strategy was an IVL first approach. So the first calcium modification device you would use was IVL. You were able, if you weren't able to deliver the IVL, use any other type of modification you wanted up front. And then after the IVL, you could also use any device you wanted as you felt was necessary. The only exclusion was cardiogenic shock and ISR, so very wide open, so left mains, osteal lesions, bifurcations, everything, and an independent SEC and angiographic core lab. So safety endpoint, cardiac death, target vessel MI, ischemia-driven TLR, and the effectiveness endpoint, successful stent delivery, in-stent residual stenosis of less than 30, and in-hospital TLF. So mean age of the patient is 73, so a bit older than most PCI trials, but we see this in the calcium space. The patients are older. You'll see a lot of ACS, so over 25% had either a STEMI or NSTEMI, with another 11% having unstable angina, and very high prevalence of comorbidities. So you see 46% diabetes, over a third prior MI, nearly 40% previous PCI, high stroke rate in the past, 13%, and a high prevalence of CKD, nearly 30%. So very high-risk real-world cohort of women. In terms of the lesion characteristics, as I said, we included everything, left mains as well, 7.3%. About 40% of patients had multiple lesions treated, the second lesion either being also a target lesion in the trial or a non-target lesion, so multivessel disease. Lesion length 33, calcium length 45, severe calcification confirmed by the core lab in 93%, and bifurcations or trifurcations in over a third of patients. So as I say, complex patients, complex lesions. We took the opportunity also to look at some female-specific risk factors, because this really has never been reported before. You see over 25% of the women had had a miscarriage before, 10% gestational diabetes, 10% gestational hypertensive disorders, and only 17% had had HRT at any point in their life, which we know is cardiovascular protective. So looking at the PCI strategies in the trial, so you'll see that 7.3% had atherectomy up front because of an uncrossable lesion, 2% had cutting or scoring up front, but we were able to use an IVL first approach in over 90% of patients. So we were really pleasantly surprised by that, considering the complexity of disease. After IVL, only 2.9 needed cutting or scoring, and only 0.4 then needed to have atherectomy because of inadequate calcium modification. So in terms of primary endpoints, so TLF was 12%, but to break that down for you, for more clinically meaningful outcomes, so cardiac death 1.3%, spontaneous MI 1.5%, and ischemia-driven TLR 1.3% at 30 days, so really low event rates considering the complexity of the patients. Coming back to the procedural MI, so we mandated that every patient had biomarkers checked post-procedure because we wanted to see this. This is not routinely done in trials, and a lot of the calcium trials only check biomarkers if you have symptoms or clinical signs of having an event post-procedure, but we did it in all patients. Actually, when we then re-adjudicate all the procedural MIs using the different definitions, you'll see that with the universal definition, which requires you to have symptoms or clinical or angiographic signs, then we end up with a per-procedural MI of 4.5%, which is less than was seen in ECLIPSE with a lower risk population. So in terms of effectiveness, you see stent delivery, nearly 99%, residual stenosis the same, and you see there that without in-hospital TLF and procedural successes based on that procedural MI SCAI definition. And just to backtrack to that, over 50% of those SCAI definition procedural MIs were just troponin rises without any clinical or angiographic or ECG changes. So again, IVL in this trial looks safe from a procedural point of view. So this is the angiographic complications. You'll see that after IVL, 2.6% had a type T dissection, no type E or Fs. You'll see by the end, they're all fixed by stenting. You'll see there was 3 perforations, again, all fixed. The perforation in the final, the column in the far right was actually a wire perforation that was residual, but again, no clinical sequelae of any of these complications. So really remarkable procedural safety rates for the technology. And then lastly, we looked at quality of life because really now, and certainly in stable angina patients, we know this is where we should be focused. And you see that the EQ5 D5L showed a 12% increase in quality of life. There was a 38% reduction in anxiety scores and a 26% increase in improvement in anginal scores. And all these were highly statistically significant. So in conclusion, PowerCD is a trial of the use of IVL in a high-risk real-world cohort of women with calcified lesions. We were able to use IVL as a first approach in over 90% of patients. There was a very low incidence of angiographic procedural complications, low incidence of cardiac death, spontaneous MI, and ischemia-driven target lesion revasc at 30 days, and significant improvements in quality of life, anxiety, and angina scores at 30 days. Thanks.
Before we go back to the cath lab, any reaction to these results? Any question to Margaret?
Yes, just only a question to Margaret. We discussed before this point is about the percentage of femoral access in the US cohort, because we have data from our registry in Italy that is called Rolling Stones. In 23 centers, we enrolled in a period of 2 years, more than 1,000 patients with IVL or atherectomy devices, orbital or rotational atherectomy. And at the multivariate analysis in the multivariate model, one of the things that impact the 1 year outcomes in terms of MACE was the use of the radial access, because I think that IVL is something that keep our procedure more straightforward, probably more simple, also in the ACS cohort patients. And so I think that this is a very important point to talk about.
Yeah, so you'll see I kind of brushed past it because I knew we were going to discuss it. But you'll see when we originally got the data, it was across all global sites of radial versus femoral. We deliberately split it up because we knew the signal was going to be from the US. So 80 in Europe and the UK, 80% of procedures were radial, 20% femoral, which you would think is probably about right because often a lot of these patients are small and elderly, and so there are a proportion of those patients where you can't do them radial, especially if you can do something where you think you need a 7. But I think about 20% is about right. In the US, it was 50-50. So I obviously now have moved from Europe to working in the US over the last 2 years. And we have managed to drive up our radial rates in our centre, which is a complex centre, now 70%. But interestingly, I do the CTOs and all the complex cases, and I'm still the highest radial user in the whole group. So I do 90% radial in all my patients. So I think it is just a comfort and cultural thing that is changing. And bizarrely, people think that in these patients, they want to go femoral because they're worried about the size of the radial, etc., and the complexity of the cases. But actually, these are the patients that benefit the most from going radial. So I think we're getting there. It's just they're still behind.
Okay.
What was also interesting was to see really this single-digit percentage in almost all the events. So it really seems to be a straightforward, safe procedure. There was this disturbing signal in terms of periprocedural MI, but I wonder whether this should be rather taken as a proxy of the severity and extension of the disease rather than a real event.
I agree, Emanuele, and I took the case out that I showed yesterday, but a lot of these cases were highly complex. Patients, elderly, the case I showed yesterday, 89-year-old women, very unstable, multiple comorbidities, CKD, etc. So very high-risk patients. And also, as we saw, like a high proportion presented with NSTEMIs, and we know those patients have higher event rates. So considering that, the event rate actually from the cardiac death and spontaneous IMI and TLR is really low. And I think the procedural MI thing really just stimulates a discussion around how we measure that. And we were discussing yesterday how the FDA is now almost mandating in coronary trials now that you collect multiple biomarkers because they're trying to figure out what they think should be the threshold of a significant event.
Okay, let's go back to Madrid and then we get back here.
Comes with the stent, but it goes actually quite easily after the preparation. I would say around here.
Ahí está bien, ¿no? So with 14 atmospheres near us, we have a beautiful expansion of the stents according to this. We can have a look to it in a different angulation. Okay. Can get a scene as you wish.
Yeah, so it opens very well, no, in all directions. Let's do an stent boost. Check also the.
There's a bit of under expansion there, as you can see.
Yeah.
Simply, we can do it. We can treat it directly without doing OCT. So high pressure balloon 4.0. Bueno.
Yeah, it's partially correct. I think it's also the bend, no? So it's an area where, of course, it's a bit more resistant, but I think it's probably the area is huge.
So nice recognition of the stents automatically by the system. Good. So let's start from beginning to end. So we have this proximal stenosis that was left untreated for the time being. Neves, we agree about that. We will check with a pressure guide wire if that's significant or not. But, and of course, now it becomes more evident with the huge improvement of the vessel. Now, the lumen profile is even much better than we suspected from the stent boost. Neves, what do you think?
Mm-hmm. No, I think it looks like the expansion is definitely over 80. Yeah, the area with the small expansion is 89%, so really very good expansion in all areas. No?
Yeah, a bit elliptical lumen there. That's probably what explains why in
the MSA is 9.4, so really huge lumen area and the stent area.
Beautiful expansion, vitreophilia positions. Okay, we are approaching
we
the
don't see
distal part.
dissections at the edges also.
Fantastic, yeah. No
good
dissection.
expansion, good apposition.
And then this is the distal stent that we did.
This is the distal area, and then we enter in the distal stent. If we go a little bit more.
So probably the only thing that remains is to make a pressure guide wire to confirm that there is no need to treat any of the other stenosis.
Yeah.
Let's make an IFR. Which is perfect. So that means that the stenosis that we have in the proximal part, we are going to show the colleagues the stenosis that you see in the proximal part is not significant at all, nor the stenosis that we have distal to the stented side. So that's very good, yeah.
You can say that both from the imaging and functional part, the result is very good in this RCA.
I don't think we need any more injections, Nieves, in this, because we have the OCT, we have the physiology.
Yeah, I don't think so. No, I think we have this injection where we have the angiogram plus all the OCT findings.
So Nieves, it's a very nice demonstration that we have absolutely normal vessel, and of course, I mean that probably accounts. The reason for that is because the amount of subtended myocardium distal to that point is not that big.
We have finished. My take-home messages from this case, really, or my learning points would be, first of all, how imaging is very helpful to understand the calcification and the types of calcium. I was actually, very happy when I saw with intracoronary imaging that the pattern of calcium we had. I knew this was going to respond really well to shockwave IVL because we had this centric and concentric calcium thick, but we didn't have areas of nodular calcium. So it was really, a pattern of calcification that goes really well with shockwave. We know that it also works in nodules, but when you have this type of eccentric, concentric calcium, you always get excellent results with shockwave, like in this case. It was thick, but it was also somehow superficial, also deep in some areas. It can also be treated with shockwave. So I think it's a case where also, even when there was tortuosity and it's a vessel that initially you can think that you can have some difficulties to cross with the IVL balloon, it went very easily there, and it allowed us to treat all the segments. And I think also learning point for me was this area where we had this resistant lesion that took some more pulses to dilate. Also, very important, the technique. Shockwave, we always say it's easy, but you have to do it properly, especially in this type of long lesions. Make sure that you don't let areas without treating. Be careful where you position your emitters, etc. So, from your side, Javier?
I think, yeah, I fully agree, Nieves. Just to give some additional points to what you said, I think that, first, we also learned that the information you can get from CT angiography can be very useful beforehand in terms of pattern of calcification. Second thing that we also learn is that with this new generation of IVL catheters, you can really navigate in situations that are quite challenging, like this one, with this heavily calcific vessel, ridges, and this very much marked bend. It's true that from the very beginning, and that's also another learning point, we went with a guide liner or with a guide extension catheter because we anticipated that would be very useful for many different aspects. We also shared some tips and tricks regarding the use of IVL using the stent boost or stent enhancement to locate the emitters in front of the plaque. Also to make sure that you debubble the balloon frequently because that increases the performance. And also the fact that we went straight from use of IVL to stenting without need to perform additional dilation with a high-pressure balloon. Obviously because intracoronary imaging was giving us a lot of evidence that the behavior will be good. And finally, from a wider perspective, from the perspective of the patient, this is a patient that had multiple lesions in several vessels, and we were able to perform ischemia-driven revascularization. We just treated what it was needed. There was no need to perform treatment of the distal or the proximal aspects of the right coronary artery. There was no need, of course, to treat that pressure that previously implanted stent in the circumflex. That angiographically looked very tight, but it was no significant at all.
Yeah, so thank you, Javier. Thank you to all the colleagues attending this session. We hope you can continue enjoying EuroPCR. Thank you.
Thank you very much.
So I'd like to start by using the words of Nieves. IVL is easy, but needs to be done properly, Simon. Can you share the highlights of this session? Was IVL done properly, as I suppose it was?
Okay, let's mark the homework. So we're going to look at the balloon expansion of the IVL. I think this is like absolutely. If I had one criticism, there's no like the final result was excellent. Okay, but the balloon expansion here with the IVL is fully up. So if you're thinking about pulse management, I'm not necessarily sure. I've done this more and more now. I put the balloon up. If it's fully up, you can move on. So this bit is done. Compliance is normal. Javier alluded to that. Balloon fully expanded, symmetrical around the wire. You know, but they put like sort of 60 pulses in that segment there. And then when they realized that this is the bit that needs all the treatment, they had 60 pulses left. But that was enough. But look here. You know, they wondered whether that was an air bubble. You know, that crossed my mind as well, but it's obviously not. This is what we see with every set of pulses. The compliance is improving, compliance is improving, compliance is improving. Okay, so we're feeling confident from the IVL that we had a real segment of resistant calcium. After we delivered the pulses, it improved a lot. We can tell that from the balloon expansion itself, but it's helpful to perform OCT and have a look. So I'll put side by side here. This is proximal here. This is where we saw eccentric calcium. We see a nice fracture through the side of that. So that's encouraging. We already see luminal gain. And let's look at the tightest segment here. This is it here. Okay, and we see fractures through there and good luminal gain. Okay, and then I think it's important, once you perform the IVL and just before you put a stent in, I think it's important to recheck the landing zones. You know, sometimes they're disrupted. You might want to extend the stent further. Sometimes the vessel's got a lot bigger if it's a very tight stenosis. So they did that here. Nothing's changed. Okay, so that's the proximal landing zone. This is the distal landing zone. So it's going to be a 40-30 or 28-30 millimeter stent. Okay, good. So the stent goes in, and this is really encouraging, isn't it? You know, you're going to implant the stent. You're not going to implant the stent at 18 atmospheres. This is 10, 12 atmospheres. And you see it fully expanded, the balloon fully expanded, so you're feeling confident. But what's really interesting, how much a balloon can sort of, you know, make the vessel look a bit better. And I'm using this a lot more, and I know Margaret is as well. You use the stent expansion, the stent booster. And I don't know if you guys can see so much, but right in that segment there, you see it's a little bit undercooked. So it's helpful. It's sort of saving. It's case efficiency, isn't it? Because you don't put that OCT back down again. You can see it on there, so you're going to use a 4O balloon, post-dilate that before you do another run. So I would post-dilate it, then do another stent boost, and check before I do my final OCT run. I think it just helps case efficiency. Let's move on here. So let's look at this, the final result. I mean, look, just look at the bottom here, the longitudinal view. It looks absolutely fantastic, doesn't it? Okay. Stent expansion within this heavily calcified lesion, minimum is 89%. It's excellent. But look at the MSA, 9.45. I mean, that stent's not going to fail. It looks great. So let's just check the top edge, bottom edge, and then go to the MSA, which is they do here. So this is the top edge of the stent. Looks great. It's well opposed. Bottom looks good, well opposed. This is the MSA, the segment here, 11.19. You know, I don't think you need to post it like that anymore, do you? An angiogram, it won't play because we're in the smart screen. And that's the end.
Thank you very much. Very well done. Angela, I still see a lot of questions there from our colleagues. Do you want to start?
Yeah, so a lot of interest in the Empower CAD, Margaret, and people are really interested in whether or not there was intracoronary imaging performed, and should we be expecting some results from that, if so?
Yeah, so we did an OCT sub-study. Originally, we had intended to put 200 of the full patient subset into the OCT sub-study, but interestingly, as a reflection of the complexity of the cases, we actually revised that down to 100 because you couldn't do OCT on a large proportion of the patients because either the disease was so severe, you were doing multiple vessels, or because the patients had CKD. So it really reflected the trial population. I think it's an important point to make that OCT is a fantastic tool, but don't use it to the detriment of the patient. And when you're doing multiple lesions and multiple vessels and you want to do lots of runs, in that situation for me, it's IVUS. So yeah, so you'll see the OCT sub-study data hopefully at TCT. And then we've obviously got a lot of the patients, we didn't mandate imaging, but we strongly encouraged it. So there was a very high prevalence of IVUS use in the rest of the population.
So that's going to be really interesting data. And Thul, do
May I
you
ask
have
you-
some
so-
data on intracoronary imaging coming out from Bali?
So it was mandatory in Bali. So we're gonna certainly, I think, a very high interest is actually in this evaluation with intracoronary imaging of whether you have achieved a preparation result that is sufficient for stenting. And we have only some qualitative things to look for, is fractures and stuff like that. We need to analyze that much more deeply and come up with, tools to use to evaluate that. And we're looking into that.
Lots more data, I think, Emanuele, to come. And Marco, you have a question for Margaret.
Yeah, one question for Margaret about, do you plan a comparison between OCT features or about plaque characteristics in women from the Empower CAD and the contemporary cohort of the Disrupt CAD CAD 1, 2, 3 or so?
Yeah, it's a great question and something that we're really interested in because there's obviously been a lot of discussion about do you see different patterns of calcium in women than in men? Obviously, we've selected a different kind of risk level of cohort from the original Disrupt trials, but I'm sure there's something we can do there around matching. So we are going to look at it, and it's going to be interesting. I know there's a number of ongoing trials in the calcium space that are also going to be looking at that, the different morphologies and different genders. So.
Any additional point? At this stage, I think it would be useful if anyone in the panel would really highlight or summarize what are the key points for proper IVL treatment. What are the key steps that we should never forget in order to do it well? Who wants to take this on? You have it in the final slide? Okay, then it will be for Angela.
I'm going to say,
Yes, please.
it's not a comment about how to do it well, but it's what I've reflected on about what IVL has brought to the treatment of calcium. And I'm going to go a little bit off piste here, and people may have heard of this before, so if you have, forgive me. There was a guy called Colin Chapman. Okay, he was an engineer for Lotus. Okay, a brilliant engineer. And his ethos about design was simplify and add lightness, okay? But I think, thinking about IVL, what has it brought? To me, it simplifies the treatment of calcium and it adds safety. That would be my, if I had Shockwave, that's what I would have printed on the T-shirt. It simplifies and adds safety. That's my take-home message.
So, Angela, I'm looking forward to see your key points. Can we go back to slides? I think they need to change from smart screen. It's always Simon's fault. Try to go back now. Yep, I think you have to go all the way through, Angela.
Really?
Yeah, just push, 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 push. Okay, it will be a nice recap of all what we have seen.
Yeah. I'll talk very quickly.
Education is repetition. Yeah, there we go. Almost there. Check, check, check. Voila.
Okay. So I think it's been a really great session. I actually have learnt a lot from everyone here on the panel and all of the discussion in the chat, which there's been quite a lot. I think, first of all, Simon has outlined the new CALC roadmap, which is going to give us a framework on how to approach these patients with calcified coronary artery disease. And I think we're going to be hearing a lot more about that. And anyone who wants to know more about that, Simon is available to walk you through it. But the case that we've seen today has been, really technically excellent. And it has really highlighted quite a number of points about the technical use of IVL, and the audience were also really interested in kind of figuring that out. So you saw Javier and Nieves discuss exactly, the technology behind the IVL balloon and exactly where the emitters were located. And we saw them use intracoronary imaging to size appropriately the IVL balloon, but then also to use things like stent enhancement techniques so that they understand where the emitters are in relation to the calcium, so they can get the best bang for your buck with your IVL balloon and use it appropriately. And and then recognising the areas where you need to apply more pulses using both intracoronary imaging and your stent enhancement techniques, which will show you areas where the balloon is underexpanded. And you can see that the result both during the procedure and in the OCT run following IVL, where we saw significant calcium fracture, and then following the stenting and optimization, where we saw that they achieved very, very large luminal areas. And then finally, my take home is that we have very exciting new clinical data coming from multiple studies. And we heard from Margaret with the Empower CAD showing both the safety and efficacy of IVL in a very complex subset of female patients, which we've not seen data on before. And there's a lot more data to come, which is exciting. So I think with that, Emanuele, I'd like to thank everybody for joining, everyone for participating. I'd like to thank the panel for all their efforts to create this session, and very much would also like to thank Emanuele, who directed the session really expertly, and I hope everybody enjoys the rest of PCR 2025.